ready for an insightful journey into one of your body's most incredible systems, the urinary system. It's truly vital for filtering, balancing, and maintaining our entire body's health, often working behind the scenes.
It really is. It's a complex, often underestimated network, and our mission today is to take all the sources you've provided, kind of distill them down, and hand you the key insights into how this system works, what could go wrong, and how we diagnose and manage those issues. Think of it as a shortcut to truly understanding what keeps your internal filtration plant running clean.
Exactly. We're going to unpack everything from what the color of your urine can tell you to understanding common conditions like UTIs and kidney stones, and even more serious challenges like kidney failure. You'll walk away feeling much more informed and maybe even a little amazed by this, well, unsung hero of your anatomy. Okay, let's dive in. To start, let's understand the core functions. Beyond just getting rid of waste, what remarkable jobs does the urinary system actually perform for us?
You're right. It's so much more than just waste disposal. This system is a master balancer. It precisely controls your body's pH, keeping it in a very narrow, healthy range, like really precise. It also secretes erythropoietin, that's a hormone that tells your bone marrow to produce red blood cells, the oxygen carriers.
Ah, okay.
Plus, it converts vitamin D into its active form, which is essential for absorbing calcium and keeping your bones strong. And of course, it efficiently flushes out water-soluble medications and their byproducts.
That's a phenomenal list. So, when this masterful regulator is humming along perfectly, what should its output, our urine, look and feel like? What's the gold standard?
Well, a healthy minimum output is around 30 milliliters per hour, give or take. Normal urine is typically a transparent yellow, could be pale straw, could be deeper amber. It's usually slightly acidic and has a mild characteristic odor. Nothing too strong, ideally. It's mostly water, about 95%, with the rest being waste products like urea, creatinine, uric acid, and various salts. Its concentration, measured by specific gravity, should fall between 1.005 and 1.030.
Okay, here's where it gets really interesting for us. What if it's not normal? What vital clues can our urine give us about what's going on inside our body?
This is where a simple urinalysis becomes such a powerful diagnostic tool. Seriously. When we find protein, or albumin, in urine, it's a critical red flag. Think of your kidneys like a finely tuned coffee filter.
Right.
It's supposed to keep the good stuff, like protein, in your blood. If protein is spilling out, it signals that the filters themselves might be damaged. It gives us an early warning about conditions like kidney disease or even uncontrolled high blood pressure. Similarly, glucose in the urine points to high blood sugar, often a sign of diabetes.
And it sounds like more than just chemistry can give us clues. What about visible signs, like just looking at it?
Absolutely. Red blood cells, for instance, could suggest infection or kidney irritation from stones, or even a tumor in some cases.
Well,
white blood cells almost always signal an infection, most commonly a urinary tract infection, or UTI.
UTIs. We'll get to those.
Definitely. And even the color and smell tell a story. Dark yellow urine just means it's concentrated, maybe you need more water. But a smoky appearance might mean old red blood cells, pink. Or red urine indicates fresh red blood cells, that's hematuria. Cloudy urine often means white blood cells are present. And a foul smell is a really strong indicator of a UTI. Even an amber color can sometimes signal hepatitis, or it could be harmless, from certain medications.
That's fascinating how much information our body provides daily if we just know how to interpret it. Before we move on, let's quickly refresh our memory on some key terms that really help us understand urinary health. Just the basics.
Precisely. Yeah, good idea. For instance, knowing that dysuria means painful urination, that burning sensation. Nocturia refers to waking up frequently at night to go. Oliguria means less than 30 milliliters of urine per hour, so very low output. And anuria is almost no urine at all, less than 100 milliliters in a whole day. Knowing these terms can give you important language to describe symptoms if something feels off.
Got it. Dysuria, nocturia, oliguria, anuria, key terms. So our internal filtration plant is amazing when it's running smoothly. But what happens when the pipes get clogged or an unwanted visitor gets in? For many, the first hint of trouble comes with a urinary tract infection, a UTI. What makes UTIs such a common and sometimes recurring problem?
Right. UTIs happen when bacteria or other pathogens enter and multiply within the urinary tract. While the exact entry point and type of pathogen vary, several factors increase the risk. Things like obstructions in the bladder, maybe not emptying the bladder completely. Certain hygiene practices, sexual activity, or even infections acquired in healthcare settings, nosocomial infections.
Okay. What are the telltale signs for our listeners to watch out for, those unmistakable signals that a UTI might be brewing?
Well, you might feel a persistent urge to urinate, even right after you've just gone, often accompanied by urgency and frequency, like really needing to go often. Pain or a burning sensation during urination, that's the dysuria we mentioned, is a classic symptom. You might also experience bladder cramping, lower abdominal or maybe back pain, and voiding only small amounts at a time. For some, especially older adults, a UTI can even present as sudden confusion, which is a really critical clue.
Confusion, wow.
Yes. And as we mentioned before, the urine itself can appear dark, cloudy, or even blood-tinged, often with a strong, foul odor.
How are these infections typically managed, and what can people do at home for prevention or relief?
Management primarily involves antibiotics, specifically chosen to target the bacteria causing the infection. Culture usually tells us which one. Sometimes a urinary analgesic is prescribed for pain relief, like phenazopyridine. That's the one that can famously turn urine bright orange.
Oh, right. Good to know that's normal.
Yes, definitely warn people about that. Beyond medication, preventative measures are crucial. Increasing your fluid intake, aiming for about 3 liters daily, helps flush the system. It's also advised to void at the first urge, don't hold it too long. And for women, the advice is always wipe from front to back. Good catheter care, if applicable, is vital. Avoiding irritants like scented feminine products or tight clothing can also help. Interestingly, some sources suggest an acid-ash diet emphasizing cranberry juice, lean meats, cereals can help acidify urine and maybe prevent certain stone formations, the alkaline ones.
That's a comprehensive approach. Okay, let's talk about something that can cause incredibly severe pain. Kidney stones, also known as urolithiasis. How do these unwelcome guests form? And what makes them so excruciating?
Yeah, kidney stones. What's truly fascinating here is how these stones develop from the accumulation of substances like calcium phosphate or uric acid,
Huh.
things normally in urine. It's often made worse by dehydration. They can be tiny, like sand, or grow into surprisingly large branch structures called staghorn calculi.
Staghorn, it's like antlers.
Exactly. They can form anywhere in the urinary tract, in the kidney itself, that's nephrolithiasis, in the ureter, ureterolithiasis, or down in the bladder, cystolithiasis. Factors like blockages, urine that just sits there, stasis, too much purine in the diet leading to uric acid stones, or even prolonged immobility can contribute. They're more common in males, typically between 20 and 40.
And the pain,
Mm.
it sounds absolutely debilitating, like legendary pain.
It can be. The classic renal colic pain is sharp, severe, typically felt in the flank, the side and back area. It often radiates down towards the groin. This intense pain can trigger nausea, vomiting, and profuse sweating, diaphoresis. It's common to see blood in the urine, hematuria. And if the stone is in the bladder, you might experience increased urinary frequency or pain during urination. Now, if a stone completely obstructs urine flow, leading to oliguria or anuria, very little or no urine output, that's a medical emergency. Needs immediate attention.
Okay, that's serious. What's done to manage these painful stones?
For the acute pain, strong pain medications like opioids are often necessary. Morphine, for example. If there's an infection alongside the stone, antibiotics are prescribed. In some cases, specific medications, chemolytics, can help dissolve certain stone types. In others, spasmolytics like oxybutynin can decrease those bladder spasms caused by the moving stone. Encouraging high fluid intake, again around 3 liters daily, and staying mobile, walking around, are key to helping pass smaller stones naturally. Critically, patients must strain all their urine, every single drop,
Strain it. Why?
to collect the stone or fragments for analysis. Knowing what the stone is made of helps guide future dietary advice and medical prevention strategies. If stones are too large to pass naturally, then surgical interventions come into play. Things like lithotripsy.
Lithotripsy.
Yeah, uses ultrasonic waves like focused sound waves to pulverize the stone into smaller pieces that can be passed. Or there are various endoscopic procedures, going up with a scope, or even open surgical procedures to remove them directly. Sometimes stents are placed to keep the ureter open.
Right, okay. Shifting gears slightly to a common men's health issue, benign prostatic hyperplasia, or BPH, is quite prevalent, isn't it? What exactly is BPH, and how does it affect men?
Yeah, BPH is very common. It's an enlargement of the prostate gland. It often happens in men aged 50 and older, likely due to hormonal changes associated with aging. The problem arises because this enlarged gland sits right around the urethra, the tube that carries urine out. Its increased size can squeeze or occlude the urethra, making it difficult for urine to pass.
So what are the telltale signs men should be aware of if they're experiencing BPH? What would they notice?
Early symptoms often include frequent urination, especially needing to get up multiple times at night. That's nocturia again. There's often difficulty starting urination, what we call hesitancy. The urinary stream might lack force, it might be weak, maybe it stops and starts, or there's dribbling at the end. Men might also find themselves straining to urinate, really having to push. In some cases, blood in the urine or reduced urine output can occur too.
That sounds incredibly frustrating, just day to day. How is BPH typically managed? And what happens after a surgical procedure, if it comes to that?
Medical management often starts with medications. Alpha blockers like tamsulosin, brand name Flomax, help relax the prostate muscles and improve urinary flow. Or there are enzyme inhibitors like finasteride, Proscar that can actually help shrink the prostate gland over time, though that takes longer. When these medical options aren't enough or symptoms are severe, surgery becomes an option. The most common procedure is a transurethral resection of the prostate, or TURP.
TURP, okay.
Yeah, TURP. With TURP, a special instrument is inserted through the urethra, and it uses an electrical loop or sometimes a laser to remove the excess prostate tissue that's blocking the flow. After surgery, careful monitoring is crucial. We watch for bleeding, infection, and make sure urine is flowing well. Patients often have a catheter temporarily, which might need gentle irrigation to prevent blood clots from blocking it. Importantly, patients are advised to avoid constipation, heavy lifting, and certain medications like aspirin or NSAIDs for a while to ensure proper healing.
Now, let's explore some more serious conditions directly affecting the kidneys themselves. We often hear about glomerulonephritis and nephrotic syndrome. What are these conditions all about? They sound quite serious.
They are, yes. These are essentially immune-related kidney disorders. Something triggers the immune system to mistakenly attack parts of the kidney. They can either start in the kidneys themselves or be a complication of other systemic conditions like lupus or, very commonly, diabetic nephropathy. The core issue is that the tiny filters in the kidneys, the glomeruli, become inflamed and damaged. This compromises their ability to selectively filter blood. They start letting things through they shouldn't, like protein.
Protein spilling out again.
Exactly. For example, acute glomerulonephritis can sometimes be a delayed reaction to a strep infection, like strep throat, that maybe wasn't fully treated weeks earlier. Chronic forms involve a slow, progressive destruction of these filters over time, often linked to long-term illnesses like diabetes or autoimmune disorders.
And when these vital filters are compromised, what signals does the body send? What are the key manifestations someone might experience?
A major sign, as you said, is protein in the urine, proteinuria. This leads to low protein levels in the blood, hypoalbuminemia. This imbalance often causes noticeable swelling or edema, particularly around the eyes, especially in the morning, and in the face, arms, and legs, along with weight gain from all that extra fluid.
Okay, the swelling is a big clue.
It is. People might also experience shortness of breath, maybe crackles in the lungs from fluid, reduced urine output, oliguria, and blood in the urine, giving it that characteristic reddish-brown or cola color. Other symptoms can include fatigue, headaches, high blood pressure, and maybe nausea or anorexia. Lab tests will confirm the kidney's impaired function, showing increased BUN and creatinine, for instance.
How are these conditions managed? It sounds like you need to protect those delicate kidney filters.
Management focuses on reducing the inflammation, controlling blood pressure aggressively, and managing the fluid balance. Corticosteroids, like prednisone, are often used to decrease that immune-driven inflammation and hopefully prevent further kidney damage or failure. Diuretics, like furosemide or Lasix, help get rid of the excess fluid and reduce the edema. Specific blood pressure medications, particularly ACE inhibitors or ARBs, are crucial. They not only lower blood pressure, but also have a protective effect on the kidneys themselves, reducing protein leakage. Dietary adjustments are key, usually low sodium to manage swelling and blood pressure. Sometimes protein intake is adjusted and fluid intake is carefully monitored and often restricted.
That brings us to kidney failure, both acute and chronic, which can be life-altering. Let's start with acute renal failure or acute kidney injury.
Right. Acute kidney injury, AKI. This is a sudden, sharp decline in kidney function. Happens relatively quickly. This means the kidneys abruptly lose their ability to remove wastes, balance fluids and electrolytes, and even produce hormones. It can be triggered by sudden events like severe bleeding, hemorrhage, circulatory failure or shock, a bad allergic reaction, an obstruction like a kidney stone, or even sometimes severe infections or toxins.
So it's often triggered by something else.
Often, yes. We categorize it by what's causing the injury. Pre-renal, if the problem is reduced blood flow to the kidneys, renal or intrinsic, if there's direct damage to the kidney tissue itself, and postrenal if urine flow from the kidneys is blocked downstream. This condition often unfolds in phases. There's an initial onset phase when the injury occurs, then often an oliguric phase lasting maybe 1 to 3 weeks where urine output drops significantly. Waste products like BUN and potassium buildup and dialysis might be needed.
Dialysis even for acute failure.
Sometimes, yes, temporarily. Then comes a diuretic phase, where urine output increases, sometimes dramatically, as the kidneys start to recover function. But during this phase, patients need close monitoring for dehydration and electrolyte imbalances because the kidneys aren't concentrating urine properly yet. Finally, there's a recovery phase, which can take quite a while, even up to a year or longer, for kidney function to stabilize. And sometimes function doesn't fully return to baseline.
And what about the long-term chronic kidney disease, CKD? This sounds like a much slower, more insidious progression.
Exactly. Chronic kidney disease, or CKD, represents a gradual, irreversible, progressive decline in kidney function over months or years, eventually leading towards end-stage renal disease or failure. The kidneys simply lose their ability to function normally over time, and waste products accumulate relentlessly. It develops slowly, often without obvious symptoms in the early stages. The leading cause globally is uncontrolled diabetes mellitus.
Diabetes again.
Yes, number one cause, followed closely by uncontrolled high blood pressure, hypertension. Other causes include long-term inflammation, like chronic glomerulonephritis, repeated kidney infections, pyelonephritis, genetic conditions like polycystic kidney disease, and even chronic gout.
How is CKD categorized, and what are its widespread manifestations? Given that the kidneys affect so much of the body, it sounds like it would impact everything.
It really does. CKD is staged from 1 to 5 based on the glomerular filtration rate, or GFR, which measures how well the kidneys are filtering waste. Stage 1 is mild damage with normal GFR. Stage 5 is a kidney failure with a GFR less than 15 millimol. Because waste products build up throughout the body, the manifestations are extensive, affecting nearly every system. Patients often experience extreme fatigue, partly due to anemia because the kidneys aren't making enough erythropoietin. Also, persistent headaches, high blood pressure, fluid overload which can strain the heart and lead to heart failure or dysrhythmias. Neurologically, they might feel irritable, lethargic. GI issues are common: nausea, vomiting, loss of appetite. Pruritus, which is intense itching, can occur from urea crystals depositing on the skin, sometimes called uremic froth.
Uremic frost. Wow.
Yeah. Urine output gradually decreases, oliguria progressing eventually to anuria, almost no urine at all. As waste products like urea build up in the brain, it can cause confusion, disorientation, mental lapses, muscle cramps or twitching, and tragically, can eventually lead to convulsions and coma if untreated. The skin might take on a dusky yellowish tan color. Lab tests show all sorts of imbalances: low calcium, high potassium, metabolic acidosis, very high BUN and creatinine, and that's severely reduced GFR.
That sounds incredibly challenging for patients and their families. What's involved in managing CKD, trying to slow it down or cope with it?
Management is really comprehensive. It aims to slow the progression as much as possible, manage all those symptoms and complications, and maintain quality of life. This often includes carefully planned periods of rest, medication management, and eventually renal replacement therapy, either dialysis to artificially clean the blood or ultimately a kidney transplant. Diet is paramount. Strict limits on potassium, phosphate, and sodium are usually needed, but they need adequate calories, often from carbs, plus vitamins and calcium supplements. Fluids are almost always restricted, sometimes to less than 800 milliliters per day in late stages. Strict intake and output monitoring and daily weights are essential.
And medication.
Lots of medications. Drugs like ApoE-alpha, Epigen to stimulate red blood cell production for the anemia, iron supplements, maybe anti-seizure meds like Dilantin if needed. Diuretics might be used in earlier stages but become less effective later. Those ATE inhibitors or ARBs are really important for lowering blood pressure and providing kidney protection, slowing the progression. It's also critical to avoid certain things, like over-the-counter antacids containing magnesium or enemas with phosphorus, as the kidneys can't excrete them properly.
Okay, given all these potential issues, understanding how doctors pinpoint the problems is crucial. What are some of the key diagnostic tests we should highlight? Things that go beyond just that simple urine sample we talked about earlier.
All right, beyond a routine urinalysis, which is still fundamental, a 24-hour urine collection is incredibly informative. It monitors kidney function over a full day by precisely measuring how much protein, creatinine, urea, electrolytes, and other substances are actually excreted. The process itself requires care. It usually starts after you discard the first morning void. Then every single drop for the next 24 hours is collected in a special container, often with a preservative, and kept cold, like on ice or in the fridge.
And if you miss one?
If you miss a single void, the entire test has to be restarted. It really highlights how meticulous it needs to be for accuracy.
We mentioned BUN and creatinine earlier as blood tests. Can you remind us what those tell us specifically about kidney function?
Sure. Blood urea nitrogen, or BUN normal, is typically around 10-20 milli-GDL, reflects the kidney's ability to rid the blood of urea, a waste product of protein metabolism. An increasing BUN can signal kidney or liver issues, dehydration, or even a high-protein diet or infection. A high BUN is often associated with confusion or disorientation, so we monitor that. Serum creatinine, with a normal range usually around 0.5 to 1.2 mg/dL, is generally considered the most accurate blood test measure of renal function. Creatinine is a waste product of muscle metabolism, and healthy kidneys filter it out efficiently. So an increased creatinine level directly reflects a decrease in the kidney's filtering ability, the GFR. It's a key indicator.
Okay. Any other diagnostics that offer a clearer view, like imaging or looking inside the system?
Absolutely. An intravenous pyelogram, or IVP, uses a special iodine-based contrast dye injected into a vein, and then X-rays are taken as the dye moves through the urinary tract. It helps visualize the structures, kidneys, ureters, bladder. Before an IVP, patients need to fast, usually have their bowels cleansed. And crucially, we must always check for allergies to iodine or shellfish, as the dye is iodine-based. Also, certain diabetes medications like metformin need to be stopped temporarily before and after,
Why metformin?
to avoid potential complications like lactic acidosis if the contrast dye temporarily affects kidney function. Then there are endoscopic procedures, like a cystoscopy, where a thin tube with a camera is inserted through the urethra to look directly inside the bladder. Can do biopsies or even remove small stones this way. A nephroscopy looks directly into the kidney. For men, a prostate-specific antigen, or PSA, blood test helps assess prostate health. Elevated levels, say greater than 10, might suggest prostate cancer, but could also be BPH or even just inflammation, prostatitis. It's not definitive for cancer on its own. And a renal biopsy, taking a small tissue sample directly from the kidney with a needle, offers the most direct assessment of kidney tissue pathology.
Moving to life-saving interventions now. For those with severe kidney dysfunction, dialysis is literally a lifeline. What are the main types?
There are two primary types: hemodialysis and peritoneal dialysis. Hemodialysis involves cleansing the blood of waste products and excess fluids by shunting the patient's blood out of the body through an artificial kidney machine, the dialyzer, and then returning the clean blood back into circulation.
Outside the body, wow.
Yes. It typically happens in a dialysis center, usually 3 times a week for about 3 to 5 hours each session. It requires reliable vascular access. This can be temporary, like a special catheter in a large vein, or permanent, like a surgically created AV fistula or graft, usually in the arm. This access site needs careful monitoring. We check for a bruit, a whooshing sound, and a thrill, a vibration, to ensure good blood flow, and watch closely for clotting or infection. Patients are weighed carefully before and after each treatment because fluid removal is a major goal. Roughly 1 liter of fluid removed equals 1 kilogram of weight loss. Vital signs are monitored frequently during the procedure. Patients are taught to report symptoms like headache, muscle cramps, nausea, or dizziness, as these can indicate something called disequilibrium syndrome from rapid fluid and solute shifts.
Okay, and what about peritoneal dialysis? How does that work differently?
Peritoneal dialysis, or PD, uses the patient's own peritoneum, the natural lining of the abdominal cavity, as the filter. A soft catheter is surgically placed into the peritoneal cavity. Then, a special dialyzing fluid, dialysate, is instilled through the catheter into the abdomen. This fluid dwells inside for a specific period, usually 4 to 8 hours. During this dwell time, waste products and excess fluid diffuse from the blood vessels in the peritoneum into the dialysate. Then the fluid is drained out, taking the waste with it.
So the filtering happens inside the body.
Exactly. It can be done in different ways. Continuous ambulatory PD, CAPD, involves exchanges done manually by the patient throughout the day. Continuous cycler-assisted PD, CCPD, uses a machine to perform the exchanges automatically overnight while the patient sleeps. Patients can often do PD at home, which offers more flexibility. However, strict aseptic technique during exchanges is absolutely vital to prevent peritonitis, a serious infection of the peritoneum. Signs include fever, abdominal pain, nausea, confusion, and the drained fluid looking cloudy instead of clear. Also, because the dialysate fluid is often hypertonic, contains sugar, it pulls extra fluid out, so typically more fluid should be drained out than was instilled.
That makes sense. Catheters also play a big role in managing various urinary issues, not just for dialysis.
Indeed. Urinary catheters are flexible tubes used for many purposes: maintaining urine flow when there's an obstruction, diverting urine away from a surgical site to help postoperative healing, like a suprapubic catheter inserted through the abdominal wall. Also for introducing medications directly into the bladder, acting as internal stents to keep the urinary tract open after surgery, or even just identifying structures during pelvic surgery. Types vary. There's the common Foley catheter, which has a balloon to hold it in the bladder for continuous drainage. The Robinson, or straight catheter, is used for intermittent drainage. Sometimes patients learn to self-catheterize. There are special code catheters with a curved tip for men with enlarged prostates, and then external catheters like the Texas or condom catheter for incontinent males. The primary insight here, no matter the type, is the critical importance of meticulous care for any indwelling catheter,
Meticulous care meaning.
meaning using sterile technique during insertion and routine care, keeping the collection bag below the level of a bladder, always, and off the floor, to prevent backflow of urine and contamination, recording intake and output accurately, ensuring the patient stays well hydrated, maintaining a closed drainage system unless irrigation is specifically ordered, performing catheter care, cleansing the area around the insertion site at least twice daily, and examining the drained urine for blood, sediment, or any foul odor. If assessment is needed, it's collected aseptically from a special port on the tubing, never from the collection bag itself.
Got it. And finally, for end-stage kidney disease, kidney transplantation is a major intervention.
Yes, kidney transplantation is a monumental procedure. A healthy donor kidney, either from a living or deceased donor, is surgically placed, usually low down in the iliac fossa in the pelvis. Interestingly, the patient's own non-functioning kidneys are often left in place unless they're causing problems like infection or high blood pressure. The biggest challenge post-transplant is preventing the recipient's immune system from rejecting the new kidney. This requires lifelong immunosuppressant medications like cyclosporine and steroids. Rejection can still happen, and signs include decreasing urine output, fever, tenderness over the graft site, and rising BUN and creatinine levels. Close monitoring is essential. Sometimes, for other reasons like bladder cancer requiring removal, cystectomy, or a non-functioning bladder, neurogenic bladder, urinary diversion procedures are performed. These create new pathways for urine to exit the body, often involving using a piece of intestine to create a conduit or internal pouch, sometimes leading to a stoma on the abdomen. Meticulous skin care around the stoma is imperative for these diversions.
Finally, let's connect all this to aging. What are some of the common urinary system changes and challenges as we get older, and why should our listeners, especially if they're older or caring for older adults, pay particular attention to them?
That's a really important point. As we age, it's very common to experience changes like increased urinary frequency, urgency, needing to wake up at night to avoid nocturia, and incontinence, or involuntary leakage. This is often due to a combination of factors: a natural weakening of the bladder muscle and the pelvic floor muscles that support it, reduced nerve sensation so you don't feel the urge as strongly or as early, and sometimes a decreased bladder capacity. The voiding reflex itself can become a bit delayed. What's crucial to understand is that incontinence, for example, isn't just a minor inconvenience. It's noted as a major factor contributing to older adults needing institutionalized placement, like nursing homes. It can deeply impact self-esteem, dignity, and social interaction.
That's a really significant impact. And are there specific risks or common issues for older men versus older women?
Yes, there are some differences. Older women are particularly prone to stress incontinence that's leakage occurring with activities like coughing, sneezing, laughing, or lifting. This is largely due to weakened pelvic floor muscles and declining estrogen levels after menopause. Here, Kegel exercises, strengthening those pelvic floor muscles, can be incredibly beneficial. Older men, on the other hand, face an increased risk of urinary retention, difficulty emptying the bladder completely, primarily due to that common enlargement of the prostate gland, BPH, which we discussed earlier. Both genders are at higher risk for urinary tract infections, UTIs, as they age. This is often associated with factors like incomplete bladder emptying, increased catheterizations, conditions like diabetes mellitus, or neurological disorders that affect bladder function. Decreased fluid intake, sometimes due to fear of incontinence, and immobility also contribute, as they can lead to urinary stasis, where urine sits in the bladder longer, allowing bacteria to multiply.
So understanding these age-related changes, what practical steps can be taken? What can be done to mitigate these risks and support urinary health in older adults?
The focus should really be on proactive management and prevention, not just accepting these as inevitable. Frequent, scheduled toileting, maybe every 2-3 hours during the day, can help manage urgency and prevent accidents, even if the person doesn't feel a strong urge. Maintaining good hydration is still vital, even if it seems counterintuitive with incontinence. Concentrated urine is more irritating to the bladder. Adequate fluid intake helps prevent UTIs and constipation, which can worsen bladder issues. Meticulous skincare is crucial if incontinence does occur to prevent skin breakdown from moisture. For those experiencing incontinence, bladder habit training, which involves gradually increasing the time between voids, and consistent Kegel exercises are really essential strategies for improving bladder control and overall quality of life. The key insight here is that many age-related urinary changes can be actively managed and often significantly improved with the right strategies and support. Hashtag tag outro.
Wow, what an incredibly detailed, deep dive into the urinary system. Really fascinating stuff. From the subtle clues in a simple urinalysis to the really intricate processes of dialysis and transplantation, it's so clear how vital and complex this system is to our overall health.
Indeed it is. And understanding these mechanisms and the potential disorders, it really empowers you, the listener, to be more attuned to your body's signals and hopefully to engage more proactively with your healthcare if needed. The interconnectedness, of seemingly minor symptoms to major system functions is truly striking. It reminds us that no part of the body works in isolation, does it?
Not at all. So what does this all mean for you as our learner? What's the takeaway thought?
Well, I think this deep dive raises an important question. How often do we truly pay attention to these fundamental bodily processes until a problem arises? Maybe not often enough. Consider how understanding your body's daily reports, like your urine characteristics, maybe changes in your voiding patterns, how these can serve as crucial early indicators. They might prompt you to seek advice sooner, or maybe adjust your lifestyle, like increasing hydration. It's like a continuous vital conversation happening between your body and your awareness. Are you listening?
A truly thought-provoking way to think about our incredible internal filters. Thanks so much for joining us on this deep dive. We hope you feel not